think we're good. All right, great. So let me get in the frame here. You're in the frame. Beautiful.
Is that okay?
Yeah, I think we're good. All right. So welcome. I'm here with Dr. Fine, and you're a psychiatrist, and you've been practicing for a long time. And my goal would be to steal some knowledge from you.
Okay.
All right? You've seen a lot.
Joe Rucklick was the one who passed Wilt Chamberlain the ball for his 100th point. That's knowledge.
We're off to a good start. All right, so basically, I would like to talk to you about, I'm coming from the primary care perspective. We see a lot of mental health issues, and I wanted to get your gestalt on some of them and how you approach it, and so that hopefully we could steal some of your knowledge, basically.
Okay.
So you tell me everything about you. When did you start? No, I'm joking. All right. So I would like to talk to, first of all, just screenings in general. So I see people for regular well exams, and a lot of times they have no complaints even, or they have medical complaints, but they don't have any mental health complaints. And I wanted to know, we have some screening protocols. I wanted to know your opinion on them. Are they good? Do you have any ideas of what we could do for screenings that would be quick and easy and profitable?
In not any particular order, I guess profitable depends on the structure of your business and whether you want the patients to come back or stay away. Screening tools in general, I think, are useless, but that's for me.
Okay.
Because if a patient comes to see me and they scored something on the something test, that really is meaningless.
Right.
What's important, and this might not be helpful in the spirit of your question, but I'm going to screen patients in a different way, which I think is the best way, which is talking to them and listening and asking questions. And I think what I'd like to do if a young impressionable primary care came to me and said, how do I get a handle on the psychological aspects? I'd say, talk to the patient, listen, and use your just humanistic skills.
Right.
If someone's uncomfortable about something, well, follow it up. Ask what's going on. Don't be afraid to ask very specific questions to assess something. If it's the cosmic waves gives you the impression that there might be a problem at home or a problem at work or something, just ask.
Right.
And I just think relating to the patient is a way better way to get a sense if there's a mental health issue than a piece of paper.
Right. So we have like this PHQ, it's like 2 questions, and you have PHQ-9, then an anxiety questionnaire. But you're saying, we just talk to them, find out where you live at home. And then what about like specific question like, hey, do you have anxiety, or how are you feeling? Do you feel like you have some problem that we want to discuss, or you feel fine mentally? Like, do you have any like...
Yeah, the more open-ended questions, the better. The more yes-no questions, the more likely you might miss something, or obviously if you don't ask a question, but a yes-no is better than nothing.
Right.
Do you have suicidal thoughts is better than nothing.
Right.
It's as simple as, so Dr. Saul, how have things been going? And then I just shut up and listen, and I'll see where you go. And if you go somewhere that begs for another question, I'll ask. If the first words out of your mouth are, things are bad, or things are tough, or things are stressed, well, I'm getting the passenger seat, and I'm going to follow this.
Right.
And let's just say that you're talking to me, and this can be done, in my humble opinion, within just a minute or two. So this is not a separate psychiatric evaluation. I would contend that as part of just a regular, normal, yearly physical, I'm just going to ask questions, and I'm going to ask, so how are things at home?
Right.
And how are things financially, and how are you doing with the kids, and how's the job? And my gosh, that's certainly going to open the door to all kinds of mental health issues if they're there.
Right. So yeah, one of the questions I always ask is, who lives at home with you? And that opens enough that I can start to get a sense of, if they're lonely, if they have people with them, if they have social support, and then maybe, because I'm always wondering how to jump onto the next level to do a screening. I think I'm going to do it from there. I think that makes sense. All right. So most people who come who are being treated for mental health, at least for the first time, they usually are coming with a problem. They're not actually coming in with nothing, and all of a sudden you find it.
And we're talking about someone who comes to see you.
Yeah.
Okay.
Yeah. So this is for primary care. By the
Okay.
time they see you, I assume you're getting people who are a little more advanced.
They're near death.
So question. My wife was acting weird, and I asked her if everything was okay, and she said it was fine. Is that okay?
Okay, wait, I'm sorry. Do that. This is a. Wait, this is you. There's a patient.
Okay.
Sorry, you spun me around too quick.
All right. So for patients who come in, I wanted to touch on first anxiety. I find like it's pretty common with patients. They'll come in and they have a lot of different manifestations of underlying anxiety.
Sure.
So I wanted to talk about what you find, like what is a typical way that they present that you'd be like, okay, this is anxiety and not something else.
Well, when I did my ER rotations in my residency, I thought a third of the patients that came into the ER, they were there because of anxiety.
Right.
And so here again, you just ask and you follow the lead and follow your lead. And in an ideal situation, you have a lot of tolerance for helping the patient with their anxiety.
Right.
If you don't, well, then don't ask the questions and avoid it and be very, problem focused on their knee or whatever. But on the other hand, if you're okay opening the door, well, just like we were talking about earlier, you just ask.
Right.
And you can ask an open-ended question, or you could say, well, that seems stressful,
right.
Or I would imagine that makes you anxious, and then you just listen to where they go.
Right. So the ones that come to me usually, I mean, just classically, they're going to have, they're worried, so they have a lot of thoughts that are intruding. They have problems sleeping. They have sometimes a lot of physical manifestations as well, but just mental manifestations. They can't control their thoughts. They're angry, they're short with people, and like, is that kind of classic what we're seeing?
Oh, well, that's a bunch of stuff. Though that could be several people you just described. That could be one person. I mean, one person could come in and say, "I can't make my brain turn off."
Right.
Okay. I mean, if you want a rapid treatment, I mean, what you could say to that patient is, well, if your brain turned off, you'd be dead. Nobody's brain turns off.
Right.
And you can't control and manage your thoughts like you. I've never had to pay $50, Shlomo, but if you don't picture an elephant right now, I'll give you $50.
Right.
And so the idea of potentially armchair helping someone to just get more comfortable with the fact that they have thoughts. Now, what I do when someone's here with thoughts, I'm a firm believer in a Freudian concept called psychic determinism, that there's no such thing as anything that happens randomly, including our thoughts. So every thought you have there's a reason for it.
Right.
And so if you're ruminating or obsessing about, I don't know, fill in the blank, there's a reason for it. So we just want to be the best detective we can be and figure out with the patient why you're having that thought. And a lot of the time in my practice, if you come up with the reason why they're having the thought, well, the thought goes away. It works that way with recurrent dreams also. If someone has a recurrent dream and you open it up to find out what's the source, the recurrent dream goes away.
Okay.
And now that's for the advanced primary care.
Yeah. So I'm just trying to differentiate, like, let's say, just classic depression from classic anxiety. So I don't think for people who are having classic depression, they'd say like, "Hey, I'm having a lot of."
I wouldn't generically. This is what I would tell a primary care: forget about psychiatric diagnosis. Just forget about it.
Really?
In discussion with a colleague, maybe it's helpful to say depressed or anxious. But first off, with those two, there's so much overlap. Anxiety can also cause depression, and depression can cause anxiety. Sorting out the specific DSM-5 diagnoses is only for the insurance company. It's only for the HCFA 1500 form. It's not helpful. I use antidepressants for people with anxiety.
Yeah.
I use anti-anxiety agents for people who are psychotic. I use antipsychotics for people who are depressed. There's no connection between diagnosis and treatment in psychiatry.
So we should see it as not a binary diagnosis, really.
The way I go about this, which I encourage you to, is you look at the symptoms and try and figure out the cause. And that's what you want to do.
Okay.
And having that kind of model in your head might decrease the chance that you're just going to give meds for symptoms.
Right.
Certainly don't give meds because of a diagnosis.
No.
And that's why bipolar disorder is so grossly overdiagnosed, in part because there's so many meds for bipolar disorder. You diagnose someone with bipolar disorder who has mood swings, and then you can put them on Lamictal, you can put on Depakote, you can put on this and that and this and that.
Right.
All kinds of patients come to see me, they say I have bipolar disorder. They don't have bipolar disorder.
Right.
I've said that 10,000 times in my practice. You don't have bipolar disorder.
Right.
Just like that.
All right. So people who have, let's say I'm going more towards anxiety, but I've seen people who are showing up, especially younger adults, men more, but they're coming with somatic manifestations. Mm-hmm. So what are some of the classic ones that you are aware of, or that you see that maybe somebody else doesn't know? Like global sensation.
You name it. I've seen it. With somatic manifestations. But something that you're going to see is someone who comes with headaches.
Headaches.
Well, sure, or like trouble sleeping, or
right.
less physical like pain,
right.
but that can happen. Less conversion disorders, but
right.
that can happen.
Right. We had a patient who was throwing up constantly, and then they got better once their anxiety was more.
Yeah. I mean, you rule out some GI stuff to the best of your ability, and
right.
what's left?
Right.
I mean, so then it's a psych issue.
Right. Chest pain's a very common one.
Sure, not as common as those others. If someone walks in and their primary concern is chest pain,
right.
We're not going to just say, here, take some Prozac and call me in a month.
Right.
But back to what I said earlier, someone comes in with headaches. How could anxiety not be making their headaches worse? And so I'm not ready to say your headaches are because of anxiety, but anxiety makes their headaches worse. I'm certainly going to be I'd be encouraging you to ask about their life
right.
and what they're conflicted about, what they're stressed about. And again, if we can figure out the source, the cause of the psychological symptoms, that's a huge step towards solving the problem, which might end up being a medication. It might end up being a change of jobs. It might be couples therapy, because
right.
now we understand that the problem is when I'm around my wife, I get more stressed. I can't go to work anymore, without a headache.
Right. The only issue, I don't want to get into this now, but the problem is we're dealing with their whole body and any medical problems now. We have 5 minutes to figure out. So it's something that's now referring to
Sorry,
somebody else.
That's obviously my bias. We're not going to be working on toenail fungus while you and I are talking, but you need to check that too.
I agree. All right. Medical workup for anxiety, obviously like TSH. If somebody's having hyperthyroidism, if somebody's having an EKG, probably if they're having palpitations, you'd hate to diagnose somebody with anxiety and they have like AFib,
Right.
Is there anything you've seen come up maybe a couple times?
No, and I don't do much of a medical workup unless unless there's physical symptoms that go along with it,
okay.
or on the rare occasion, knock on wood, that I'm treating someone and they're not getting better when I would have expected them to get better.
Okay.
But the good news for me is they tend to get better with either therapy or meds.
Right.
And so what you just mentioned about the TSH, oh my gosh, I'm not going to be critical of you getting a TSH.
Right.
I think we're talking about I don't know what, 1 out of 500. That's going to be the.
Right. No, it's not common. But I've had 2 patients and they just didn't know it. But usually they had a
right.
goiter, and so
exactly.
And the heart rate's high. So
exactly.
It's using your brain. But I'm just wondering, if there's any. But
no, there's no lab test that I would recommend that primary cares need to do more.
Okay.
It literally.
No pheochromocytoma.
No, and that's not a commentary on primary care's ordering tests. It's a commentary on. I think it's unlikely that you're going to uncover metabolically a source of the anxiety.
Okay.
But again, they come in and you're thinking to yourself that they've got diabetes. That might help their anxiety.
Right.
If they're not sweating so much, they lose some weight, their sugars are better, et cetera.
Right. Okay. Now, in terms of treatment, so let's say we diagnose it and we think like this is a problem maybe they've had in the past, and it's kind of affecting their life. We want to start instituting some treatments. So I assume you're a big proponent of therapy, like talk therapy.
Huge.
Right. So I try to get everybody who, even if I'm thinking about meds, or like the first step would be like, I want you to get into somebody to talk to about this. I get a lot of resistance.
Mm-hmm.
A lot of resistance. They want a quick fix. It's hard. It costs money. It's hard to get in. They don't want to spend the time. How do I get
I
that?
I hope this is helpful. It might be too far out in left field, but my guess is this is what you're looking for. There is a patient I saw in California 20 years ago, and he comes in. He said the FBI's put transmitters in my ear,
Right.
and otherwise he's okay, but the FBI put transmitters in his ear. So the chances of him accepting my treatment when I say, well, that's a psychotic symptom. I mean, that's a delusion. Let me give you an antipsychotic. No matter how sweet I make it, it's probably not going to be acceptable. So what I need to do is I need to create some connection between me, the patient, and the diagnosis. And so what I did in this particular case is I said something like, well, that's got to be really anxiety provoking, the fact that you're always being monitored.
Right.
And then he says, yes. And then I say, I've got a medicine for anxiety, for that type of anxiety. So now he's willing to take the medicine because we've made a connection
I got you.
between I and the underlying cause.
So you want to sell them on their diagnosis first.
And that's why it's a nice thing, what I told you about earlier. Let's toss the diagnoses out the window, because technically DSM, I mean, it's a delusion. But the fact of the matter is, if you think about it, paranoia is just an extension of anxiety. You got a girl who's nervous before her violin concert,
Right.
and you say, honey, you'll do fine. Okay, now she's got sweaty palms, and you say, you give her, I don't know, you give her some propranolol. She says, no, I'm going to fail, or maybe one step more. I think people in the audience think I'm going to fail. Now, what I just did is as quickly as I could, just created a spectrum where at one end, she's paranoid and she's psychotic. At the other end, we're not going to give her any meds. We're going to give her a pat on the back and say, you're going to kill it. So that's why I think it's okay to think of paranoia, psychotic stuff, as an extension of anxiety. Now, there are times where, no, it's silly to do that.
Right.
And we have to be clear with our patients that, no, this is a psychotic symptom, this is an acute manic episode, this is whatever.
Right.
But consistent with the example I gave you, that would be the way I would try and connect with your patient that might not do the therapy or readily or be resistant to it. So here's what that looks like in real time. Tell me if I'm wrong, but what's going on at work and home is driving you nuts. And then they say, yeah. And then you say, and so what's your plan of what you're going to do about that? And they say, I don't know. I don't know.
That's what we're
I say, okay, so I've got an idea of someone who actually is really good at helping people in that situation when they don't know what to do. So I've made, ideally, a connection with the patient about the problem, which is they don't know what to do about the job in the home, and I've connected to them to the treatment, which is this person, like Dr. Fine, is an expert at sorting out those types of problems.
Right. Yeah, I hear you. Okay. So let's say we get them to talk therapy and they're seeing a therapist and they feel better, but it's affecting to the point where they can't do what they want to do and they want to consider medication.
Okay?
All right. So first line, I want to talk about it. So first line, SSRIs.
For what?
For anxiety, or for what we're describing our patient.
Okay, so for me, no, there's a lot of options with respect to medications, and there's a lot of variables. But
Okay.
if you're just asking, can I use an SSRI for anxiety? Yeah, probably. But I'm okay using a PRN benzodiazepine for certain patients in certain conditions.
Okay.
Let me exaggerate. An easy one is I'm scared to death of getting on the plane.
Right.
Okay, here's one Xanax. Have a good
Right.
flight.
Right.
On the other end of the spectrum, which it can be more complicated, is someone who's been on an SSRI or two,
Right.
or someone who's already been on some benzos. So in fairness to you, I'd be happy to entertain the idea. Let's see if we can come up with a cookbook flow chart. Right. But I think there's lots of variables to try and manage.
Let's talk about some, like, so if somebody has performance anxiety, and then class you would try like a beta blocker.
On paper, that makes sense.
Yeah, maybe.
And that's the board
Right.
answer to the question. Okay. If it's I would probably use a 0.5 milligram of Ativan.
Okay.
And I think it'll be more effective than the propranolol.
Okay.
And personally, I'm more worried about her being dizzy out on stage than I am of her getting addicted to my one, Ativan pill or whatever.
Right. Okay. Sometimes hydroxyzine you're using, like. I've had some pretty. I mean, you ever use it?
There's nothing wrong with it. I almost never use that because when they come to see me, Dr. Saul's already given them hydroxyzine.
Right.
But my goodness, you can
Safe.
take that long term, safe. That's simple.
Helpful
Oh my
sleep.
gosh.
Right.
Oh yeah. Why not?
Right.
Why not?
Yeah.
Plus, again, this is part of how you interact with the patient. There's the placebo quality
Sure.
and I'll entertain you with a quick story. Back in their internship in the ICU, there was a guy who I think he had terrible liver problems, and I probably shouldn't tell you this story on camera. But they called me in the middle of the night. He needs something to sleep. What do I do? I said, well, tell you what, give him something called acetaminophen, and tell him it's really strong stuff, and we're going to just use it just tonight only. Nurses told me he slept. So in fairness to the universe, placebos are real. I mean, they really are.
Right.
And so the way you present the hydroxyzine without being a lunatic, I think that's important.
Yeah. Okay. Other medications that do you ever try Buspar on its own?
It's a placebo.
Doesn't work. Okay.
With us.
All right. Now, I've heard you tell me before, and I don't know, you tell me correct. So let's say we wanted to get into SSRIs. Lexapro for young men, you like that? You like that?
No, I use Prozac more than all the others combined.
Oh, really?
And I'll make a case for it, but I'm completely fine if you told me you're a Celexa guy. There's nothing wrong with that. I like Prozac especially in younger people because it's been around longer, it's been studied more, and I'm okay giving it to an adolescent because of that. I kind of like Prozac because if you forget to take it, it's no big deal. When you stop Prozac, I think you can just stop it abruptly. We're stopping Zoloft abruptly, especially Paxil. Oh, if you miss one dose of Paxil, it's a mess.
Right.
So Prozac is easy to get off of. It's easy. If you skip a day, it's no big deal. And it tends to be a little bit more activating than the other SSRIs, which oftentimes is a good thing, and it's just as good as the others at decreasing obsessive and ruminating thinking. In fact, the standard SSRI treatment for ass-kicking OCD is 80 milligrams of Prozac.
Right. Just in the dosage, do you just get them, what do? You start off lower?
20 is one size fits all. I'd give a little old lady 20 milligrams. And if for some reason she was nervous, I was nervous, okay, fine, 10. It's fine, but I start 95% of Prozac patients on 20.
You don't build them up; you just give them 20.
Oh yeah, that's an advantage of Prozac over Zoloft, which you clearly are going to start low and work up. Celexa 20 milligram start, Lexapro 10 milligram start. The starting dose is kind of the therapeutic dose, and I'm fine with that. And so again, that's. And Prozac is also, although they all pretty much are, dirt cheap. So if someone didn't have insurance, it should cost them $5.
And then in terms of classic side effects, so you can get tired, weight gain, men or anorgasmia, anything else like that you classically?
I would, with all due respect, I would say it completely differently. I don't say anorgasmia. I say delayed orgasm.
Delayed, I'm sorry.
And I say that's what I will tell a patient is delayed orgasm is common. And some guys don't mind that. Some guys it's frustrating.
Right.
But it's very unusual that someone will stop Prozac because of the sexual side effects. But I present it as delayed orgasm.
Okay. Well, that's what it is. I misspoke.
I will tell people that you're likely to have more vivid dreams, and it's no big deal. I mean, enjoy the in color stuff.
Right.
And what I'll say is after that, the side effect profile really does drop off. And so I will then say some people get more tired, some people have trouble sleeping, some people get headaches, some people gain weight, some people lose weight. When Prozac first came out, it was part of a weight loss program. And the reason it got dropped is because it wasn't consistent. I see Prozac as kind of weight neutral and maybe even just a teeny bit towards the weight loss, but certainly people can gain weight when they're on the Prozac, which I don't know how much that is a pharmacodynamic issue as it is that maybe if you take it and you're less anxious, you're less worked up, you don't burn up as many calories, you're more chill. It's
so you eat more, yeah.
Yeah.
Okay, so that's good. Now, people, do you have a lot of patients or a considerable amount who fail Prozac and you try other SSRIs, or generally they're pretty good and then you'd switch to augment something else?
That's an art. That's not a complicated one. That's not science at all.
Okay.
If a patient comes in and sees me and they've been on Prozac only, if we came close to benefit them, but then there's a side effect on Prozac, whatever it is, a sideways switch to an SSRI is okay. But if they had a side effect, well, the other SSRIs are just as likely to cause it. But it is true that you will have a patient who does well on one and not the other. I won't try a third SSRI. That doesn't make any sense.
Right.
I'm more likely to raise it. I'm more likely to augment it with something else, which could be several different things. Or I would go to Wellbutrin as a completely different thing. You switch.
And you switch. You're not adding. Okay.
I don't. I think I get points in heaven for taking people off meds, not getting them on meds.
Right.
And so someone comes to me, which is not unusual, and they're on 4 or more meds. Oh, the last thing I want to do is add a med. Now, it could happen, but you cannot convince me that you need Lamictal and Vibrid and Paxil and Rexulti, whatever. So it's better to take off. And so on Prozac alone, first time it didn't work, I'd take them off the Prozac, and then I'd probably try something different. Again, it's a little bit of an art. Wellbutrin would be the first drug I'd go to outside of the SSRIs, unless there's a contraindication, they've got a seizure disorder, or a seizure history, or they're anorexic.
Right. Do you ever worry about QT prolongation?
I don't.
Okay.
I don't think I've ever
You've
gotten
never seen a case where that caused it?
No.
I heard citalopram is like the one that's like the most.
And
you don't use that much any of those?
And so this is easy for me to say, but I've been doing this long enough, so forgive the potential cockiness, but I'm my own standard of care now because I've been doing this long enough. And I don't remember anybody, knock on wood, ever having a literal problem. Right. And so to tell you the truth, the last thing I want to do is check an EKG, see a little QT, and then stop the medicine if it's working. So this isn't bag over the head, but I don't think it's necessary.
While we're on the topic, totally not related to, but for patients who start on AD stimulants, do you get an EKG then?
I don't.
Okay.
I don't. I think stimulants, especially in the doses I'm going to prescribe, once you go above like 30 of Adderall, I think you're wasting your time. Right. I'm not convinced at all that somebody needs 60 of Adderall. But
you've never seen a patient go into VTAC from
but I'll tell a patient when they start it, your heart might go faster. I mean, you could raise your blood pressure, and so then if symptoms come my way, like they talk about racing heart, okay, well then now we can look at this like differently or diagnostically, or I've got these headaches, or whatever.
Yeah. Sorry to digress.
Okay. No,
so you'll go to Wellbutrin. And then do you add on, what's your opinion about adding on, you just give them 10 pills of benzodiazepine if they have panic attacks along with their anxiety so that they can carry it in their pocket?
That's an option. That's absolutely an option.
That just because it gives them confidence to go outside. And
I think that's a lovely option. I don't usually do that, but there's doggone nothing wrong with that. Okay. And then you and the patient can deal with it. If they say, I want more, I want to take it every day, and then, I mean, I'm fine with, I've got plenty of patients who take benzodiazepines every single day and they've been on it for years.
Yeah, I'm not.
Right, that's not our goal,
no, right.
But at the same time, they're fine.
I'm just not comfortable, because then they're beholden, So when it comes to that point, I try to get them into a psychiatrist.
Oh yeah, there's nothing wrong with that.
Yeah. What about adding on, augmenting with, so would you add anything to a SSRI?
Sure. And again,
I
don't have a flow chart. If there's these symptoms, do this. If there's these symptoms, do this. But it's a remarkably legitimate option if they're on Prozac and they're not getting better to add Rexulti or Abilify instead of switching to Wellbutrin. Okay. There's nothing wrong with that. Why would I lean towards Rexulti or Abilify? Maybe because they're more agitated than anything, or that's like more of a, or there is like subtle psychotic stuff, delusional, little more kookiness.
But you wouldn't do, I don't know, you wouldn't do Seroquel for somebody who's having anxiety. You wouldn't add Seroquel.
Why not?
Why not? With depression.
Why not? Seroquel is going to be a reasonable medicine if they're having trouble sleeping, and like they're agitated, or they're. And clearly, the Seroquel for sleep is more of a hammer than a hydroxyzine.
Right.
But I see that as a pretty darn safe, simple thing.
Right.
I don't think Seroquel augments antidepressants as well as Abilify and Rexulti.
Okay.
Those are, and in the low doses, those are helpful for depression. I hear secondhand that there's psychiatrists who will use Rexulti as a first-line treatment for depression. I don't do that.
Okay.
But in the higher doses, and I've seen this literally many times with Abilify, it's not going to be helpful for depression. Let me go off on this quick tangent.
Yeah.
Abilify 2 milligrams for a week. If you're not improved, 5 milligrams for a week. Sometimes the patient will end up coming to see me because they're not better on 10 or 15 milligrams because the doctor just kind of like, it helped for a while, so I'll give them more. But at 10 milligrams or more, Abilify is not going to help depression at all, and stopping the Abilify is probably going to be therapeutic. So that's just with that. I don't tend to see that with Rexulti, and I think Vraylar is used for that too.
You talked about adding Zyprexa.
I love Zyprexa. I have lots of patients on Zyprexa. Zyprexa is not so much an augmentation of an antidepressant. That's more the less sedating antipsychotics, like Abilify, Rexulti.
Okay.
Zyprexa is, if a patient walks in to see me and they're really anxious, they're not sleeping, they're not eating,
Right.
I've written the Zyprexa prescription before I've even said hello.
Right.
And I'm exaggerating, of course, but I think it's a wonderful first-line drug for some patients with panic attacks because they're also not sleeping or they're not eating.
Right.
And that's a primary care presentation. And I'm fine if a primary care gives someone, based on body habitus, you give them a 5 milligram pill, tell them to break it in half, and if you're not better in a week, go to the 5 milligrams. Oh, I think that's completely reasonable.
Mm-hmm. Yeah. And that one definitely makes you gain weight, though.
That is a weight gainer.
Yeah. Okay.
I have given Zyprexa to fat people, but it's with caution, and it's because other stuff hasn't worked, and I'm positive this medicine is going to help you, but you need to work on the diet and all, and then we have to follow certain labs.
So if I'm trying to get a good idea, let's say I work in the middle of nowhere, and there's no way I'm getting any psychiatric help. Is there any approach that's different in the treatment, the pharmacotherapy treatment of anxiety and depression, first line, and then adding something on?
So let's separate out, although I'm not a big fan of the specific diagnoses. Let's set out anxiety and depression. If someone presents and they're more anxious, I think if you out in the middle of nowhere, if you've got some Ativan, some Prozac, and some Zyprexa, you're going to be able to pharmacologically take care of 95% of the people that come to see you out in the middle of nowhere.
Perfect. So SSRI, adding on Zyprexa as augmented
if I need to. Yeah, and there's a medicine called Symbiax, which is a combination of Zyprexa and Prozac.
Are you kidding me?
No, I'm not kidding you. And the reason I don't prescribe Symbiax is because it fixes the amount of Zyprexa and Prozac. And also it's going to be more expensive. It's going to require prior authorization. And so, but both Zyprexa and Prozac are easy to get.
So you're pretty safe giving like 5 milligrams of Zyprexa that they take every day. That's along with an SSRI.
If they were, I'm going to start 5 milligrams if there's, I'd like to be more specific, but if there's an agitated quality. Otherwise, I'm starting a half a pill.
Yeah. Okay.
And a week is plenty of time for the Zyprexa to help, which is also nice because this is a very typical a presentation. Someone comes in with rip-roaring panic attacks.
Yeah.
I will give them Prozac and Zyprexa, and again, they've probably been seen by somebody else because I might not start with the polypharmacy right now.
Right.
But the Zyprexa will help right away.
Right.
The Prozac will help later.
Right.
And so there's the very reasonable plan of the Zyprexa for a couple of weeks, and then we take the Zyprexa away, and then they're on Prozac alone.
Okay.
As opposed to telling that incredibly anxious person, start taking this, it'll take
That's
3 or
really
4...
great. I never thought of that.
It'll take 3 or 4 weeks to work.
So
well, what am I going to do in the
both.
meantime?
Right. So you start both, and you don't have to use a benzo. You could just do the both, and then you take... That's great. Okay. Other few meds. Cymbalta, when they have pain as well. What's your opinion on that?
On paper, that's what we're taught. That's what we're told. I don't know how much of a drug rep thing it is.
Okay.
I would say that's an 80% drug rep thing because SSRIs have been shown to be very helpful in pain syndrome. You know from your board exams that tricyclics are helpful in pain. So the fact that we have Cymbalta, which is sort of like a kind of like this combination tricyclic SSRI thing, it's fine. The downside of Cymbalta is it's hard to get off of.
Right.
The teeny downside is there's a little finagling with the dose, whether you start at 30 or 60. I'd probably start at 30, but there's not going to be any good evidence that Cymbalta or Prozac is a better antidepressant. So a lot of it has to do with your comfort level. And I had mentioned before, I got Prozac is fine.
Right. No, just sometimes we're dealing with somebody who has really chronic back pain, and we're trying to deal with a few.
I think this goes back to something I said to you earlier. I don't know how much that's the placebo for the doctor because we know, again, on the board exam, you check the box that says Cymbalta is better for the pain. I don't know how much that's where we were sold, but the fact that you think that's the case, that's lovely to tell the patient.
Okay.
In other words, this is an antidepressant.
So it's a placebo for me too.
Absolutely. Absolutely. Placebos all around.
All right. Quickly. All right. So with depression, I just wanted to touch on it, but you kind of, the way you presented it, it's not, what time is that? We're good?
Yeah. Well, I got to stop in it shortly.
Okay.
Very short.
So with depression, there's also the screening questionnaires, but you would do the same thing. You would just talk to them. I mean, classically, they have problems getting out of bed. They feel tired. They have loss of interest.
Trouble with sleep, interest, feelings of guilt, worthlessness, low energy, concentration, appetite, psychomotor retardation.
Right.
The SIGI CAPS is the mnemonic.
Right. And with that, would you say that you have to worry more about suicidal issues when people are depressed over anxious?
I'm sorry. Worry about suicidal issues if what?
If somebody is more depressed versus somebody who's more anxious.
No. Here the diagnosis doesn't matter.
Okay.
What matters is previous attempts. Are you thinking about it now? Is there a substance abuse problem? Do you have access? Any plan? So that again, that has nothing to do with the diagnosis.
And you have no problem asking. We should always ask that for anybody that has.
Right. And you can go into it in a maybe a more subtle way is better. But if someone's been down, how down? Like when you really get down, you think of suicide or death. Those thoughts go to your. Oh, absolutely. Asking directly as possible is better.
Right.
And the more it's connected to the conversation, I think the more likely you're going to get a positive answer if it exists, as opposed to, do you brush your teeth twice a day? Yes. Any suicidal thoughts? No.
Right. Just we'll end on this. What about non-therapeutic or non-pharmacological, like healthy ways of managing this? You want to make sure somebody's getting enough sleep, exercise, eating okay. Like, what's your opinion on all that and how it affects your mental health?
Oh, yeah. It's huge. It's huge. So living a healthy life. This is not a direct answer to your question, but I'll often use the work, love, and play model. If you can work and enjoy what you do, and you can be in a loving relationship where you can give love and receive love, and you can go out and do stuff for fun, you do not need me. And if you're missing 2 out of those 3, you're my patient. And so we can reverse engineer that. So advice to a patient that's non-pharmacological is to make sure that they're doing something that they enjoy, they're being productive, that's the work. Are you in a relationship where you can give love and receive love? It doesn't have to be a marriage or a girlfriend. It can be your puppy or whatever. But you've got a relationship with friends, and then are you out there having fun? And so if you're doing those 3 things, I think that's there you go. That's hitting for the cycle, hitting for the mental health cycle.
Perfect. I think we got a ton of info. I really appreciate it.
You're welcome.
Thanks so
My
much.
pleasure.
All right, we got to do this again sometime.
Okay, good.
All right, let me